Welcome to Hope Ahead, Checking Your Processes. I'm your moderator, Raianne Melton, Director of Clinical Services for Axxess. Hope is the most significant regulatory change hospices have faced in many years. Today, we're going to talk about step one in preparing for the transition from the hospice item set to the hospice outcomes and patient evaluation. We're going to begin with a quick poll. Has your organization started any preparation or training for Hope? Please enter any questions about the content we're going to talk about today in your control panel, and Jennifer and I will address as many as possible at the end of the presentation. And while we're waiting for the poll results, let me welcome Jennifer Kennedy, Vice President of Quality, Compliance, and Standards for Community Health Accreditation Partner, known to most of us as CHAP. Jennifer, thank you for joining us today.
Oh, it's my pleasure. Thanks for the invitation.
So before we begin talking about Hope, let's take a minute to discuss the announcement from CMS on Friday, February 14th, about the suspension of a hospice special focus program. Thanks to grassroots advocacy, the hospice special focus program is suspended. Do you have any thoughts on what hospices should expect moving forward?
Yeah, I have several thoughts. Yay, the first one. Because, I all along I have believed that the algorithm that CMS developed wasn't doing what it intended to do. So, following all of the news and all of the regulatory rulemaking and the rollout of this program, and seeing what happened with the first cohort of 50 hospices, it was clear that the many of the hospices drawn into this program shouldn't have been selected for it. So I'm actually grateful that CMS is pulling back the special focus program. And what we do know is that they're pulling it back, and we will most likely see it reappear in future rulemaking.
Wonderful. I know that there were a lot of cheers that went up when we heard the announcement, for sure. Well, let's move back to Hope. We're going to discuss how to prepare for the transition from HIS to Hope. And let's start with the why. Can you share why hospices must review their current processes and identify their baseline performance?
Yeah, absolutely. First of all, I would just like to say we got here as CMS progresses and aligns all of their provider types. It was inevitable that we would get a standardized assessment tool. And I think I've said this to you before, Raianne, is I always think of hospice as the little caboose on the Medicare train. So what eventually comes to one provider type will come to hospice. And we watch home health for and take our cues from them for what could happen down the line. So just as we prepared for HIS many years ago, and that was based on more of an extraction of data out of a current EMR or whatever tool, assessment still played a big part of it because it affected the data that was extracted out. With Hope, it is an assessment tool, and it dovetails in with that COP at 418.54 comprehensive assessment, and it makes it not only for CMS to see data that is based in part on that particular COP, they're pulling additional data items out of that assessment process. So if you want to do well, this is a standardized assessment tool. If you want to do well, then you have to look at take the temperature of your organization. how do we fare on our comprehensive processes and outcomes right now before we even go into using a whole new tool? Do we have gaps? Do we have any, whether they're logistical or person-centered or process-centered, do we have gaps of those sort that would benefit us to look at before we have to be pressed to put a whole new tool in place and a whole new set of processes in place?
Perfect. And, one of the reasons I was really interested in speaking with you about this is through reading your blog series, the Hope Assessment Tool series. Starting the journey really gave me so much insight into the due diligence that every hospice agency should be doing now to prepare for Hope. And it is a veritable treasure chest. And we are going to share the link for the blog series at the end because it is a very good read. As hospice organizations grow, the opportunity to hire trained quality managers whose sole focus is quality assessment occurs. But for most smaller hospices, the administrator and clinical director wear multiple hats, including acting as quality manager. As you think about practice gaps, what guidance would you give those individuals working in multiple roles to identify gaps that could impact success with Hope?
Yeah, medium and small organizations are going to have their own unique challenges ramping up to the implementation of this tool. And I think as I have worn multiple hats in an organization when I was 2 feet in a hospice, you have to do really intentional planning in terms of, all right, I'm going to spend time on this many hours a week. I'm going to dedicate these resources, whether they are financial or staffing resources for different parts of the ramp up to the implementation. But it's going to be a lot of planning. You can't just hope to work it in because if you do that, the time is ticking away. And, we're already approaching the end of February, then it's going to be March and so on. And then when your EMR is going to be ready to do their testing with you and education, you can't rely on just starting from that point moving forward. There needs to be baseline assessment of your current processes, of your current outcomes. You need to give your staff education education right now, in addition to what the EMR is going to provide for your staff. And all of this is going to take planning out when are all these things going to happen. I know staffing's tight. You might have people out there that are quality, they're regulatory or compliance, and they may even be going out and doing a visit here and there. And I understand that our patients are our mission. They are our priority. But in order for us to stay in the game, to survive this requirement, you have to plan intentional time before the due date actually arrives.
I totally agree. I love thinking about don't put it on the back burner because you will get burned for sure.
Yeah, for sure. It's just, it just does. Compliance is not an event. It's a continuous process. Quality is a continuous process. So if you think of the ramp up to Hope as not an event, but a process in the time that we have until October 1st, then I think you're going to be in better shape to meet it.
I totally agree. And, thinking about with HIS having the submission of 2 documents per admission and discharge, and then moving to Hope with the submission at the 30-day, within the 30 days of now up to 4 visits, admission, the hospice update visit number 1, and the hospice update visit number 2, plus discharge, that's
Right.
going to take some, management and focus and thinking about what processes are you going to put in place in order not to have a gap there. It's going to be super important. Let's see if we have any poll results so far. So this is exciting news. 67% of those who have responded say yes, they've started some preparation, and 33% say no. So what I would say to the people who have said yes is congratulations, strong work. And what I would say to the people who have said no is it's not too late. Well, you can start today at the end of this webinar. So good news. So moving forward, Jennifer, what questions should hospices be asking about their current practice gaps?
So I think you have to use your quality process, what you do with identifying all your practice gaps. First of all, what is the gap? And what's the reason for the gap? Is it a process issue? Is it a logistical issue, meaning that there's a problem putting the data into the EMR or the particular form that the ER has developed? Is it an understanding problem, an interpretation problem? And is it, I guess, a specific person problem? So you can only know these things by looking at your data and seeing if you see trends, right? If we see a trend with Jennifer, the nurse, then I have to talk to Jennifer. And I'm talking about HIS right now because that's what we're working with. When we get actually into the HOPE tool, you're going to be doing the same types of things in the first few months. Is you're going to be looking at your outcomes. Now, remember that CMS isn't going to use the first bit of data that they're collecting to use it for anything. They're not going to use it for it's an attenuation period, essentially. So, I mean, that's the good thing. But I think developing your processes now, looking at what you have in place, knowing that you're going to have to do, as you mentioned, additional tracking, 2 HUV visit, hospice update visits. We have to intentionally track symptom follow-up visits as well. So it's additional tracking. Who's going to be doing that, right? Who's going to be paying attention? Who's going to cue the clinician? Is it up to the clinician? And if it is, who's going to cue them that it's coming up or it's late or what have you? So I think looking at your current process, figuring in what needs to happen as a result with the HOPE assessment tool, meaning that we have much more to track now with this tool than we did with HIS. Plus, we want our accuracy to be as good as it can be. And I mean that in 2 different ways. I mean that we're answering the questions correctly, meaning that we're taking information from the patient, using that guidance manual and entering it in the way CMS has mapped it out, so that you have the best outcome on the back end. It may not matter today because we only have 2 measures that are coming up, and they're not coming up in terms of public reporting for several years because of data collection. But it gets you in the habit of making sure that your data is as accurate as possible, that each clinician that collects the data has an understanding of how it should be reported, how those questions should be answered, because down the line, Raianne, your payment might depend on how accurately you answer those questions. So I know that was a long-winded answer to your question, but I think there could be several gaps. And by looking at what your gaps are now can help you plan and anticipate for where your gaps could be with the implementation of the HOPE tool.
That just excellent points. One follow-up question there, with the symptom follow-up visit having to occur within 2 calendar days and, really looking at, are you missing visits currently? And what's the reason behind missing visits? Is there any strategies that you can suggest in terms of how you strategically look at the gap in those visit gaps?
Well, we have to go back to let's take that away. Why are visits being missed? Is it, you and I have been around the block quite a while, right? I've been doing this over, close to 30 years now. It's why are there any missed visits? Then we can go on to figuring in in 2 calendar days, right? If missed visits are happening because of staffing issues or convenience of staffing, then there's a problem right there, right? If visits are being missed because the patient is saying, I don't want one today. I just am not up for it, and it's documented as such. Then that's a good reason for a missed visit, right? Or the patient has, transitioned to GIP, and now we're in a 24/7 care setting. So I think you have to look at a missed visit should always be on, I think, everyone's quality docket. What are we missing? What are the gaps? Why are we missing them? So that you can track a trend and figure out the reasons that it's happening, if it's happening quite a bit. I think if you go back to 2014, when CMS was just starting to get hospice quality going, there was the timely pain assessment within 2 calendar days. I don't know if you remember that.
Yes, I do.
This is kind of in terms of the timing, at least, similar to that, although the intent is different, right? And organizations who did that for a short amount of time did have some problems with getting somebody out there in 2 calendar days, because it's not a phone call. It's an actual visit of getting somebody out there. So it's going to take a lot of, I think in the beginning, or, it probably ongoing, to make sure that the outcomes of the assessment are looked at very carefully. And if there's that moderate or severe outcome for pain or non-pain, we have to make sure that that's communicated so that it gets either on the schedule, if it's not the same care manager that's going out, so that visit is not missed.
I agree completely. Another thing that I have noticed in my hospice career is, we expect processes to be based on policies, and there's policy and processes, but then there's the actual practices,
right,
that organizations create to get the job done. And, when we look at submission of those records, I think that is one thing I would just strongly recommend, is that when you review your HIS submission process, don't only look at your policy and procedure, but look at the actual practices that your staff are using to submit those records.
Yeah, I couldn't agree more. And as you mentioned in the beginning, there are up to 4 required record submissions per patient. There is no record submission for a symptom follow-up visit, but that doesn't mean that you don't do it and it's not documented, because it's going to be assessed by, somebody, whether it's a whether that CMS requires that for a surveyor to look at somewhere down the line, or whether that's going to become an audit issue. We don't know what's going to happen beyond right today. Even though you're not submitting the record, you have to do it. It's a compliance item because it's there in the final rule.
Absolutely. And I think that, as I think you and I talked about our long careers in hospice, and after 20 plus years, 30 plus years of thinking in that 5-day comprehensive visit, and then in benefit periods, really doing that paradigm adjustment where we're thinking in comprehensive assessment the first 5 days, HUV number 1 between day 6 and 15, HUV number 2 between day 16 and 30. When I first saw that, I was just, holy cow, I just have never thought that way in my hospice practice. So there is going to be a paradigm shift that, our hospice agencies really need to wrap their arms around as we move forward.
Yeah, absolutely. And I think it would behoove providers to also, maybe go back a year and look at what their length of stay percentages have been. I live in Maryland, and the short length of stay is very high here, meaning that, less than 10 days it is 7 days. It's very, very short. The turnaround is very quick. So depending on length of stay, and if it's a short length of stay, depending on the patient's status, how are you going to complete, or are you even going to complete an HUV, right? Even HUV 1, right? So I think that's something you should be doing anyway. Should be analyzing length of stay across your census, right? And doing a retro look at that, and continuously doing that as part of your quality profile. But if you see that you have a really high short length of stay, you don't. If that's it, you don't want your clinicians to think that they don't ever have to do HUV 1 or even HUV 2 for those patients who fall into the longer stay bucket, right? And symptom follow-up could be a more prominent issue for short length of stay patients as well, right?
Absolutely. And when you think of the symptom follow-up visit can be triggered at the admission assessment, HUV number 1 and HUV number 2, you're looking potentially at 3 additional, well, maybe not, we wouldn't think they were additional, but 3 additional documentation events for HOPE that are in-person assessments. So it is, again, a really big paradigm shift. But let's go back to that future payment. Over the years, we've seen home health Oasis evolve, and currently in home health value-based purchasing, the impact of the home health Oasis assessment is 35% of the total calculation. And for those of you who never wanted to know anything about home health, that's where I was before I started working at Axxess, but I got a quick education on it. And what I do understand about value-based purchasing is that there are winners and losers in value-based purchasing for home health. And you can have, based on your Oasis documentation, your claims data, and your home health CHAP surveys, you can receive up to a 5% increase in your Medicare reimbursement, or that's the winners, or you can receive up to a 5% decrease per episode. And there's a lot of room on the continuum. It might be a 1% increase 2% decrease depending on your performance. To me, this is a window into the future of hope. And CMS has stated that the long-range goal of hope in hospice is payment reform. Can you share your insight into the future impact of hope?
Yeah, and I agree with everything that you laid out there. Again, we have to sort of look to the greater environment of CMS. CMS has always been charged with cost containment and high quality of care for their beneficiaries, right? So we've seen since 2010 with the Affordable Care Act that CMS was charged to develop payments for providers that do both of those things, maximize quality and cost contain, right? So since we are now receiving a standardized assessment tool, that's what the OASIS is, that's what the MDS is for nursing facilities, it would make sense that we will, with the implementation of this tool, be on a track for pay for performance some years down the line. And it will take time, just like it did for CMS to develop the OASIS E and that HHV value-based purchasing model. You go to pilot first, it has to be developed, then it has to be piloted. All of those things would need to be happening in order for CMS to assess viability of a payment model of that sort, right? And you're right, it can giveth and it can taketh away in terms of payment. But what I do know is that the last projection of the CMS trust fund was due to run out in 2030. So I think CMS is always going to be looking for ways to provide care to Medicare beneficiaries, but also do it in the most cost-contained way that they can without sacrificing any kind of quality. I think that providers who have been working with other payer sources may have or may be experiencing this type of a model already. So if you have a little bit of, a taste of the medicine, so you will say, of how it works. But providers who don't only deal in Medicare and really don't deal with other payers, it could be a shock. So I think, in my estimation, the prudent thing is to start preparing your organization, even though we're early days here. But looking ahead to the future, when you're talking about strategic goals, who we're going to do business with, and out in the outside of the Medicare, that healthcare marketplace is full of pay for performance. So I think providers need to get into that mindset, know that it is going to be coming at some point down the line, and figuring out how they are going to meet that challenge once it comes.
Agreed. And one other thing, OASIS started in 2000 with OASIS, and now they're at OASIS E1. What we've seen with Hope is CMS has added a new section on skin conditions, Section M, and they really expanded Section J, which is health conditions, including added the death is imminent question there, added a question about neuropathic pain, and of course, all of those symptom impact questions. Do you foresee in the future that we're going to be moving towards a more in-depth and robust assessment like OASIS?
I think it's possible, although, home health, hospice, two different animals, right? Mm-hmm. I think there would have to be some really thoughtful planning about what they want to do in terms of doing with that outcomes data, how they want to form measures moving forward.
Mm-hmm.
When CMS started down the road of HOPE, and you said one of the goals is payment reform. The other one is to produce ongoing measures for the hospice quality reporting program. And early in the development of a standardized tool, it was always the intent for CMS to develop measures, patient level measures, right? That would actually be levels down than what we're collecting right now. And trying to get a window into more of what's happening during that hospice stay. So I think, could we match apples to apples? No, I think we will. The intent could be similar between home health and what's developed for hospice, meaning that when you look at some of those measures, they're very patient level in home health. That's what CMS wants to get to in order to really assess the quality of hospice care.
Thank you. Great insight. We do have a question in the chat, and it is, does it have to be an RN that makes the HUV 1 and 2 visits? Can it be an LVN?
So no, the HUV visits have to be made by an RN. The symptom follow-up visits can be made either by an RN or an LPN or an LVN.
Excellent. That looks like that is the only question in our chat. So, oh wait, I have more. I shouldn't have. I spoke
That's
too
great.
soon.
Well, you know what? Let me tack on to that last question.
Sure.
The reason the HUV visits are RN only because they're intended to be a vehicle to updating the plan of care. The RN is the manager of the plan of care, so it wouldn't necessarily track that the RN should be that one person making the assessment and then coordinating the update to the plan of care.
That's absolutely. Next question. Do you anticipate direction on how to score impact to make the answers less subjective?
Give me that one more time, please.
Okay. Do you anticipate direction on how to score impact, the symptom impact, to make the answers less subjective?
I don't know if CMS is going to give us any more direction than what is in that manual at this point. I think that the more questions that providers send in to CMS to ask specifically about either an item or a section of items, the more CMS will be forthcoming with specific answers and guidance. So I wouldn't expect that they're going to give us anything more than we have right now. As we get closer to implementation, I think the FAQ portion that CMS will be putting out, it's like a trickle now with FAQs. Once we're in full implementation, I'm sure the FAQs will be a waterfall for sure.
And I think that is something that's going to be new for us in those symptom impact questions is that they're not a rating of the severity, intensity of the symptom. It's how is the patient reporting the impact of that symptom. Right. So I think that for me, it's another paradigm shift. Because, I think as a old, hospice RN, I think about, your pain rating on a scale of 1 to 10, with 10 being the worst and 0 being no pain, that's how my mind works. So I think that, again, as we learn more and as we, think about the intent of the question, I think that's going to provide some insight too, in my mind.
Yeah. I think that's really brilliant. And I think when we're talking about prepping and getting ready and training, it might be beneficial to do some case scenario role playing to get ready for this symptom follow-up visit. And you're right. They gave you a couple of little suggestions like, is it affecting your sleep? Or is it affecting your ADLs, right? And beyond that, they didn't really give any additional guidance. So I think organizations will have to figure out what they want to ask that will give the full scope of the question to the patient so that you can get back what you're hoping to get back from that patient. I think we should ask for more guidance from CMS as well. And I definitely think case scenario role playing would be a good way to train that one out.
Absolutely. Yeah, absolutely. Okay, next question. Do you think there will be more emphasis on pain and payment tied to its management?
Well, if we look at the first two measures, they're already developed. They're not going to be publicly reported for some years, fiscal year 2028. It's the target. And that depends on CMS collecting all the data, looking at it, cleaning it, and seeing what the data looks like. So that's the projected time frame. So we already have two measures developed that are based on pain or non-pain symptom impact. Now, whether you're going to be paid on that, I don't know if that would be something down the line. But again, if you go back, now I love to read rules when they come out. I just love it. That's weird, I know. But if you go back, rule after rule, many years, CMS always cites that it is one of the main purposes of hospice is to provide comfort care, right? That's what we do. And that can involve pain or non-symptom pain control, whatever that symptom might be. So could there be payment linked to more measures based on pain or non-symptom pain outcomes? I think it's possible.
We'll have to wait and see.
We have to wait and see. So let's get through the two measures that are developed right now and see how that comes out before we start, worrying about other kinds of measures that aren't even developed yet. And remember, when the way that CMS works is that they will most likely develop a technical expert panel for development of additional measures based on the HOPE assessment tool. And that means that when you see that notice come up, you, Raianne, me, anybody out here on the audience could throw their name into the hat to serve on this TEP or technical expert panel to weigh in and give CMS guidance as future measures are developed.
Wonderful. So thank you so much, Jennifer. We're sending our participants away with action items today. Check your processes, look for gaps, create process improvement plans. That's your first step in the due diligence in preparing for HOPE. And Jennifer, I just have to tell you, I never fail to gain valuable insight when I read or listen to your wisdom. So thank you so very much for partnering with me today.
Well, thank you so much. That's a very nice compliment. And well, shucks. Thanks. I appreciate being able to be on. I'm passionate about what I do, as you are, and helping providers has been most of my life in the hospice realm. So I am very pleased that CHAP is a partner with Axxess, and I think providers out there, by availing themselves of your information, of the information that we're putting out, as well as keeping track of CMS information, you're on the good road to being ready for HOPE.
Absolutely. And I would say at Axxess, we understand Hospice's educational and operational challenges while implementing regulatory changes. If you want to learn more, please plan to attend these upcoming events. Join us on March 5th for part 2 of this series, Hope Ahead, Axxess Prepares the Way. On April 10th, join Jennifer, Greg Grabowski, and Amy Rose, who will join me for part 3 in this series, Hope Ahead, Hope Ignited. But the main event occurs on May 5th at an in-person Hope Ignited workshop at Axxess's Growth, Innovation, and Leadership Experience in Dallas. There you can meet Jennifer, Greg, Amy, and myself in a 3-hour workshop where you should expect to be educated, work through scenarios, and learn how to train your staff efficiently. Later this week, expect an email with this webinar recording and links to Jennifer's Hope blog series. This email will also include registration for our upcoming Hope webinars and for the Agile event, including the Hope Ignited workshop. Thank you for joining us today. I look forward to seeing you at our next Hope webinar. Thanks.
Thanks, everyone.
Thank you for joining Axxess On Demand. Visit Axxess.com for more on-demand videos, industry resources, blogs, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.